welcome back to part 2 of the SIBO Doctor podcast with Dr. Paul Anderson. And let's jump right back into it.
Yes, it does cross the blood-brain barrier. And that is one of the reasons why it causes more brain fog.
And so, in your opinion, which patients do you think are more at risk for D-lactic acidosis?
So I think there are a few things we observed, but it was not consistent across all of them. So we did try and look at some of the predisposing factors that are also common to SIBO and to gut dysmotility and to gut dysbiosis. For example, we looked at PPI use, and we found that about a third or 40% of these patients were taking PPIs, not all of them. And the PPI use in the brain foggy group versus the non-brain foggy group was similar. The second thing we looked at was whether there were any medications they were taking other than probiotics, for example, opioids, that would interfere with gut motility. And sure enough, there were about 28 or 30% of them, they were on opioids. That was also affecting gut motility. But then we measured gut motility also. We measured stomach transit time, small bowel, and colonic transit time, and there was no difference in the transit time between this group and the non-brain foggy group. So that per se would not explain the occurrence of brain fogginess. So I think the probiotic use, the PPI use, the opioid use, and dysmotility were some of the key predisposing things that we wanted to identify in this group. And as I said, yes, we found it, but it was not a very strong discriminating factor between the two groups.
Okay, so another question I had as you were talking, I was thinking about the local pH changes from the lactic acid buildup actually does have or as far as I know, has some effect on motilin and therefore motility itself. So the question is it the overgrowth that's occurring in the small bowel that's affecting motilin, or is an already existing motility issue affecting this, that probiotics can actually stay around longer in the small intestine and cause this effect in some people? We're saying it definitely just in some people.
I think that is possible. I mean, it is hard to discount that somehow these folks were either predisposed. Now, we can build a case very easily. For example, if you are a PPI user and you've taken away acid from the stomach, your gut you've taken away an important defense barrier, which is acid. So your gut is exposed, potentially, if it were exposed to bacteria, it could colonize it. Whereas if you have normal acid, the acid will kill most of the bacteria. So you can now see if not just the bacteria in routine food, but you're now consuming large amounts of probiotics and you're taking PPI, you have now created that potential environment for colonization of the probiotic bacteria in the small bowel. Another scenario would be someone who's taking opioids. So if you're taking opioids, you're going to slow stomach emptying, small bowel emptying. So, small bowel has, as you know, nice built-in features in all of us to prevent colonization. It is the most active gut motility organ. It is extremely active. It produces lots of MMCs all the time. It also is the organ that is the most secretory organ in the gut. It produces, several liters, about 6 to 8 liters of fluid a day. It is the largest immune organ in the body, is a small bowel. So it has a lot of built-in immunity to fight off all of these things. And so for all of these reasons, it is very hard to colonize the small bowel. But then, if all of those factors are interfered with, if your motility is slowed down, if you're not secreting, opioids also are anti-secretory. So if your secretion is not good, if you are on PPIs or whatever, you're predisposed, or you're diabetic, or you have an underlying connective tissue disorder, then inadvertently you have messed up the gut normal motility and secretion, and therefore you're not predisposed. So that is how potentially some of these people got it.
And it's always a little challenging for us educators who have been teaching our practitioners and patients. A lot of patients actually listen to this podcast, that probiotics are not colonizing per se, but as Dr. Rao was mentioning, when the conditions are right, then you can have an overgrowth potentially of an organism that's supposed to be just a transient pass-through and have other regulatory effects where they belong in the large bowel. So, but again, when conditions are right, and this is why this is so fascinating, because a lot of us prescribe very strain-specific probiotics. So, for example, we have very good evidence for Lactobacillus plantarum 299V, which is a strain specific for IBS. Very good evidence that will actually affect certain aspects or symptoms of IBS, in particular with hypersensitivity and etc. So, we like, for those of you listening, it's not that this is an anti-probiotic talk. We're talking about a very specific situation that often correlates with SIBO, which is a motility problem. So,
but I think the important point to make is it is one thing to talk about giving probiotics to people with certain illnesses. It is another thing for otherwise healthy individuals to be taking billions and billions of bacteria. So there is a distinction. I'd like to call that out because it is important. I mean, there is a myth in the general public's mind that probiotics are like multivitamins, that they can just take this and somehow it confers extraordinarily beneficial health on them. I don't think there is evidence to support that. I think that's important to bring. But it is a different story when you've consulted a physician or a healthcare practitioner, you've explained the symptoms, and they're trying to treat the gut dysbiosis or certain specific symptoms using appropriate strains, under controlled conditions, under monitored conditions, which is a completely different scenario.
Yeah, but completely agree. Completely agree.
That I think is the big challenge. Now, the other issue also is what you just mentioned is it is a totally unregulated, uncontrolled industry. Now, I'll give one other example here. When you go to a store and pick up a multivitamin pill, it tells you, okay, vitamin A, it has X amount of units, and this is 50% of your daily requirement, or 100%, or whatever. Roughly, what you should be taking, and well, if you're not eating enough, if you're not eating many fruits, spinach, etc., maybe you should take a vitamin A pill. But here, we have no idea. We have no idea how much we should be having, and also we have no idea that whether it's getting to the place, which is totally unknown. Very little research has been done in very few strains to demonstrate that these are actually getting to the site. So I'll just to finish off there, I was just asked, this was just curious, I just read a paper just yesterday, which has just been published in Cell, when one of the top ranked basic science journal. It's a very intriguing paper from a group of basic scientists in Israel. And it's a complex study, translational, basic, and so on and so forth. I don't want to go into all the details about the study, but I'll call for people who are interested to read about it. But it's all to do with probiotics and gut function and so on. They do raise one interesting concern. One of the concerns they did was they gave antibiotics. They measured the gut microbiota before, and then they gave antibiotics, and then they gave probiotics and measured the gut microbiota again and tried to see whether the antibiotic-induced dysbiosis was corrected or rectified by the probiotics. Also, they were trying to find out whether those particular probiotic strains, and I can't remember what strain they used, whether they were able to recover those strains in the stool of these individuals and microbiota. So what they found was very interesting, and I think this will have to be confirmed, like our study will have to be confirmed. What they found was, number one, that the strains were not consistently obtained in all the subjects. Only few subjects, they could really pick up the strain. So what's happening to them in the others, we don't know. The second thing, which I thought was most concerning, particularly for me and for others who are using, is what we knew is antibiotic-induced dysbiosis, which I do, and that's one of the areas I actually prescribe probiotics regularly in my practice. They claimed that when they gave probiotics, those individuals had a much more disturbed microbiota. And it took much longer for their microbiota to recover as long as they were on probiotics, which is a very unusual kind of a finding. I mean, but it's a very, I would say it's a very high quality work that they've done. But the point that I was trying to, I think, but this study was done, if I'm not mistaken, in healthy subjects. I don't think it was done in patients. I read this in a hurry and I had to report that. But just to bring up the issue that, that there are some things that we have to pay into consideration, but I think it's a different issue when we have patients who are coming with healthcare problems and they're seeking the advice and guidance of a practitioner such as yourself or myself. That's a different story. But for them to just venture into a supermarket or try to self-treat themselves, I'm a little concerned about that. That's the point I want to make.
Yes, and I would agree on that. I don't think this is basically an anti or pro probiotic conversation. I think we are in basic agreement. I don't know the reference that you talk about. I'd love to look at the study because I think that the body of evidence certainly is heavy on the side of probiotics in terms of prevention of diarrhea, of antibiotic-induced diarrhea, etc. So that is early days. I'd have to review that. But, like I recently listened to Dr. Rob Knight, who's really a preeminent probiotic researcher, and who did a lot of research into into microbiome before and after antibiotics and how quickly it bounced back in different sites, vaginally and digestively, etc. So we do know that there are certain situations in which it definitely doesn't bounce back easily. We do know that. But what I wanted to talk about also is that he himself says that these organisms that we're taking orally are not our native species. They're not organisms that normally colonize the gut. And so now, and I'm one of those people that definitely takes that on board, and I educate other practitioners about this archaic term of reseeding when you take yogurt or probiotics, because that's not what happens. It's about your own native species being under the influence of external species that sometimes have a regulatory effect and a metabolic effect, etc., to kind of coax them back. But I think the only thing that will really coax back your own native species is prebiotics, and potentially at some point where we all can take crapsules, from FMT crapsules, where we actually get very specific strains, because we are so limited with what we are even prescribing. We have only a handful of probiotics that is available for us for oral consumption. And when you look at the pie chart of what is actually growing in your gut, it's just fairy dusting. Probiotics are mostly, I think their best use is when they're used for their intended purpose, which is symptom control for very specific purposes, whether that's like I said, IBS symptoms ranging from constipation. We do know some strains affect on some level motility, and some affect hyperalgesia and just sensitivity, gas and bloating in some instances. So we do have data on strain-specific probiotics. And I think that's where we need to push the research further. And we need to see, do these strains of Lactobacillus acidophilus, of salivarius, of Bulgaricus, etc., these delactate strains under certain conditions, do they pose a risk to these patients that normally would not respond in a negative fashion to these probiotics?
I agree. I agree.
Okay, that was a bit of a rant there. Sorry about that. Another question about, let's see here. You talked about ammonia. That's another thing. Do probiotics, does your normal microbiome affect ammonia change, and how does that occur in your opinion?
So I think, ammonia is again produced both in the small bowel and in the large bowel, predominantly in the large bowel. And that's again, bacteria is one of the key um, product. And I think it is part of both fermentation and metabolism that is normally taking place in the gut. Now, in our group, of course, we measured it. I said only in a couple of individuals there was mild elevation. But liver is such a phenomenal filter for this. And your liver has to be significantly compromised before you will accumulate large amounts of ammonia in the body. The first pass mechanism, so once we produce ammonia in the gut, it is first exposed to the liver. So that is where the ammonia gets completely filtered and it really detoxified. So the body will not see. On the other hand, if the liver is not functioning, then that ammonia will just filter through the liver and get to the brain and everywhere else, and that's when you get liver failure and coma and liver encephalopathy and so on and so forth. So we didn't see high levels of ammonia in this group, and I doubt it that we will see them in the vast majority of patients unless there is coexisting liver dysfunction.
Do we know, or what are the other effects of D-lactate on the body besides brain fog?
So I think D-lactic acid is a toxic substance. It can poison the kidneys. It also interferes with blood viscosity, and I think those are some of the main. And in the gut itself, I think it will have an anti-motility effect. It does slow down gut motility. So, which I think was one of the things we are probably seeing in these people is, one of the first things that they would say once they get better, they said, "Oh, I'm hungry, I can eat." Of course, their bloating and distension is gone, and they're having more normal bowel function and things like that. So I think it has a slowing effect on the gut. It has a brain foggy effect on the brain. And, one of the questions that people have asked, well, how do you really define this brain fogginess? Of course, you've seen a lot of patients, and now I've seen a few. I think it's almost intuitive. You recognize it and they will tell you. But for the purpose of a study, we had to come up with a definition to help them. And we are actually, by the way, we've developed a questionnaire that we're validating right now, and we hope within a year we will validate that. But we use these 5 symptoms. One was a difficulty with concentration, poor memory, the mental cloudiness, mental confusion, or impaired judgment. If a patient reported 2 or more of these 5 symptoms, and for at least 3 months, then we said, well, you have brain fogginess. So it was not like somebody had brain fogginess for a day or for a week, or if they had only one of these 5, then we wouldn't call them brain foggy. So we were trying to be as diligent as we could in making sure that we had a comprehensive group of patients who would meet some minimum criteria. So I think it is important to define this group better. It is important to make sure that we're picking out. I'm sure there are people who have more subtle changes and they may have a more subtle illness, but we wanted to be clear that we would have a pure group and we would examine them very meticulously.
Well, Dr. Rao, this has been so stimulating for our thought. Where are you going next with this? Are you planning a bigger study to confirm your findings? And can you tell us more about that?
So I think, as I said just now, one of our first steps is to really use a validated questionnaire, which has been a little criticism of our study that, how do you define this group? It's a very vague symptom. I'm sure people have gone through the same rigmarole when they try to define fibromyalgia, when they try to define IBS. Luckily, we now have some Rome criteria and there are other criteria that help. So we are trying to really develop a proper validated questionnaire. The second thing we wanted to do in this new prospective study is not only to evaluate the diagnosis, which we now have the diagnostic criteria well laid out, and we know how to identify D-lactic acidosis and SIBO and so on, but also to do a very diligent follow-up. In other words, we will bring them all back at a period of time, either 6 weeks or 3 months, and then we will repeat the tests to demonstrate that not only their symptoms have gone, but objectively, the brain fogginess has cleared and the D-lactic acidosis is gone and the SIBO has cleared. So we're going to test them pre and post to make the strong connection that this was what we made in our preliminary study. So we're going through the due diligence process of establishing all of that. And that will probably take us another 3 years, I think, before we'll be back with that result.
We don't have 3 years.
That's what it takes.
Yeah, it does. It takes, I'm too impatient to ever be a researcher.
Well, I know. See, just to give you an idea, this paper actually took us 2 years to publish. Since it went to the very first journal to the journal that published it. So, and that is not to do that the science wasn't there. The science was already there, but we have a lot of challenges with our peer review process and acceptance. And if it is something new and something out of the box, then there are most who are non-believers. So it takes time for them to accept this. So it did.
Yeah, and I can already hear clinicians asking the question. So, okay, I have a patient with severe brain fog. What's the best way to evaluate or test for D-lactic acidosis?
So that's a very good question. And I think that's one of the best questions that I would like to answer. This can be done anywhere in the world, literally. I don't see any reason that it can't be done. So glucose breath test, as you do it in your area, in your practice as well, and it can be done there. The only steps you need to find out is the D-lactic acid assays. There are only specialized labs that do it. So I'm sure there are labs in Sydney or Melbourne and so on. I'm sure that they probably will be doing this, but you have to contact them and find out. And what we do is we bring the patients fasting in the morning. We have them pass a urine sample. So the D-lactic acid we are measuring in the urine. The reason why is we send our specimens to Mayo Lab, and Mayo actually advised us to do it because it's much more stable in urine and both for detection and measurements than it is in blood. Blood measurements is much, much more tricky. So unless you have an assay set up in your own lab, it's very hard to do the D-lactic acid in blood. Whereas L-lactic acid can be done virtually in any lab in the country. I mean, all labs do L-lactic acid, but D-lactic acid is special. So you have to collect your urine and you collect your blood for L-lactic acid. You give them a glucose solution or any sugary drink, and then collect again urine at 1, 2, and 3 hours. Blood at the same time. And the urine samples, of course, have to be sent frozen to the lab. The blood ones will go to the blood lab straight away. So is simple.
Could you do just urine? Does it have to be as well,
no,
like to correlate with blood?
The reason for the blood is because there are a few patients in this study, I can't remember, there were 4 or so, or 3 or 4, in whom the D-lactic acid was flat and the L-lactic acid went up significantly. In a few, both of them went up, and so on. So there are some strains of lactobacillus, which I learned as part of this research, that apparently only produce L-lactic acid. So it is hard to completely pick up the D-lactic acid in them because the amount of D-lactic acid are not easily measurable in these individuals very well. So I think it is just to offset those groups. It is better to measure both of them when you're already taking the pains of measuring it, and that can be done. With regard to SIBO diagnosis, the breath test and cultures, the duodenal aspirin culture can be done anywhere. So most endoscopists, if they put their minds to it, they can easily do this culturing very easily. So that is the way I would diagnose both the bacterial overgrowth and the D-lactic acidosis.
Okay. Very good, because I know that, I definitely will be looking at D-lactic acidosis a lot more closely in those people that are more incapacitated by the brain fog. I have plenty of people that get improvement almost immediately when they get treated for either SIBO or SIFO, when they have one of their primary symptoms is brain fog. So that I know is very much associated with that as well. But for those that are not responding, I think it's a really fascinating area to focus in and to kind of get more information on. So I really appreciate your diligence with looking at that research and hopefully to give us more insights in the future. So thank you so much, Dr. Rao. Do you have any last parting words? Can you tell us where to find you if patients are listening? Are you completely booked to the gills? Can people still find you?
No, you will be surprised. People are trying to reach me even from down under. So I'm actually encouraging them to try and find yourself and find others who have a strong interest and more interest, a passion in this area, who are willing to listen and help these patients, which I think is sorely missing in the medical world today. And I think, but if people do want to write to me, or people do wish to come, if they wish to travel all the way here, they can always find me. I'm at the Medical College of Georgia in Augusta University in Augusta. But they can certainly email me at srao@augusta.edu, srao@augusta.edu, and they should be able to, I'll usually respond to them within 1 to 2 days.
Wow, so that is very kind that you gave your email address. Well, I don't know
if they're going to read my paper, it's there. So I think.
Oh, okay. Yes, that's true. I did see it there. Yes. Okay,
but I think that's.
Yeah. And I think a lot of your, like I said, your bio and contact details and link to the study all will be in the show notes. So thank you so much for your time. I know it's getting late where you are, so we really appreciate your insights and everything you do. And I hope I see you soon at another conference.
I look forward to that, Nirala, and I think good luck to all the listeners of your program. And I know you do a great job, and I'm really appreciative of you really bringing me on and helping to educate, which I know is your passion. So good luck with all your educational endeavors.
Thank you so much, and see you soon, Dr. Rao.
Bye-bye.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.